Alright gang, here it is, the day you have been waiting for, and I'll be honest, I have too. This class has been a real pleasure to teach, but I'm looking forward to it being over just like you are. As with everything, it's nice to get something off the to-do list and on the to-done list. So after today's lesson, you should be ready for your final exam. So if you've made it this far, you have successfully navigated 17 lessons, 17 screencasts, 18 counting that little bitty one I did at the start of the semester. And through that process, we've learned all about the history of athletic training, we've learned about protective equipment, legal issues, and then we've made our way toe to head and now to back, looking at specific injuries. So congratulations, hopefully you feel better equipped to go on and do whatever it is you want to do, whether that's coaching or going into an allied healthcare profession, or maybe this has even sparked your interest enough to consider pursuing a career in athletic training. If that's the case, bravo, I'm pretty excited about that, because that's the goal from day one. My hope is to share a little bit about this career that athletic trainers call athletic training. So with that said, just like before, we're going to make our way through the anatomy of the spine and look at the injuries and their treatment for spinal injuries. Okay, so starting with the functional anatomy of the spine, we know that the spine can move in a number of different directions, all three planes: flexion and extension in the sagittal plane, right and left lateral flexion in the frontal plane, and left and right lateral rotation in the transverse plane. We don't get much movement at all in the thoracic region because we have ribs there, so most of the motion that we get in the spine will be relatively small from segment to segment, but the fact that we have our entire vertebral column through which to move means that those small contributions to motion add up, and we end up with the range that we're after. Okay, so we have both superficial musculature, that is oftentimes kind of prime mover in nature, and then our deep musculature that is usually intended for precise rotation and more finite movements. They are critical to normal functioning of the spine. And what we see in a lot of cases is with low back pain, we get inhibition of those muscles. And when those muscles are inhibited, we end up with a spine that's more prone to injury because its dynamic restraints rather, aren't doing the job that they ordinarily would do. Okay. So at the level of C1 and C2, this is C1, also referred to as the atlas, and C2, referred to as the axis. We see the dens of the axis actually serves as an axis of rotation for that dens to rotate around. And you see these saddle type joints here. This is the articulation between the C1 vertebrae and the skull. Okay? And the transverse ligament keeps that in position where it needs to be. Okay? If we look at the vertebral structure making our way down the spine, we see that it is a column of bones that is more readily established for weight bearing lower in the column, and more readily established for range of motion higher in the column. Kind of think about it like a pyramid. It wouldn't make any sense to build a pyramid with the tip down in the dirt and the base up in the sky. We want the broadest, most able to bear load portion of the structure lower because of gravity. So our lumbar vertebrae have this large vertebral body. They also have these big, thick, heavy spinous processes, and their job is to bear load. As we make our way up the spine, the thoracic vertebrae also interact or articulate with the ribs, and then in the cervical spine we see kind of a relatively small spinous process, especially compared to the lumbar vertebrae. No ribs and lots of potential for range of motion. Now, the sacrum itself is actually composed of 5 vertebrae that are fused together to form a singular bone, and then the coccyx can be composed of a few bones itself, and it's fused together at the same time. And sometimes we can actually fracture that coccyx. We land, slip on the ice, fall on our rear end, and can sustain an injury. So if we look at the actual structure from top to bottom, we see 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, a single sacrum, and a coccyx. Okay. Now, when we talk about nerve roots, it's a little confusing because C1 actually passes between the skull and the first vertebrae, transverse processes. So even though we only have 7 cervical vertebrae, we have 8 cervical nerve roots. So if you ever see C8 on a list when you're looking at dermatomes or myotomes, you think, well, there's only 7 vertebrae, how are there 8 roots? It's because we've got 1 at the top and 1 at the bottom, so that adds up to a total of 8. Now the disc itself is intended to serve as a shock absorber. So here we see what would be the posterior aspect of the disc and the anterior aspect of the disc. We've got this tough cylindrical annulus fibrosus that resists motion, and this gelatinous nucleus pulposus that provides shock absorption. Now these are referred to as laminae. This is basically composed of layers, almost like a tree trunk would be. And in cases of disc rupture, this annulus cracks or fissures, and the nucleus is allowed to protrude out. Sometimes it'll be a bulge, sometimes it will actually be a fissure. And the problem with the nucleus pulposus is that it is caustic to nerve roots, so we get chemical irritation in addition to physical irritation. So if we've got a bulge, we get compression. If it fissures and we get nucleus out of there, now we've got a local irritation that can be highly painful. Okay. When we look at how these vertebrae kind of line up on one another, we see the disc in between adjacent vertebral bodies. We've got a longitudinal ligament that provides stability side to side. We've got a posterior longitudinal ligament. We've got a supraspinous ligament. So we see it's almost like blocks stacked on top of each other that have been taped together. And that tape, in the form of ligaments, helps provide a lot of stability. And then we also have articular surfaces on each of these facets. And any one of these could potentially be a source of irritation. We can get a little synovium in there. We can get a friction problem. And then we also look at the disc itself could also be a source of irritation. Okay. So what we're dealing with here is a very heavy amount of anatomy in a relatively small location. So after we've made our way from the wrist and hand, where we can kind of pinpoint pain easily, we see kind of the opposite end of the spectrum in the back, where it's very, very difficult to pinpoint the source of the pain. So here you see the 8 cervical nerve roots that we talked about before, and once we get past C8, they pretty much align with the body above them. So T1 through 12, L1 through 5, S1 through 5. Alright, so spinal injuries are some of the more frightening things we deal with as athletic trainers, because if we manage this inappropriately, it could very well lead to death or a very different life for the patient. So this is something we don't handle lightly. It's something that we practice regularly, is how to evaluate, and then once we've made the decision that it is a likely cervical spine injury or spinal injury period, then we proceed with the utmost caution. And although I've got 2 pictures of football here, this in no way, shape, or form should lead you to believe that these injuries only occur in contact football. Any athlete could suffer a spinal injury. Okay, so in our assessment of the spine, we go through this OPQRST, just like always. We're looking for immediate threats to life. If we look at the mechanism of injury, we want to rule out a spinal cord injury as soon as possible. Okay? We're hoping that it's extremity related as opposed to spine related. So what happened? Did they hit someone or did they hit you? Was there a loss of consciousness? Any neck pain, numbness, tingling, burning, shooting down the arms, down the legs? A quick motor screen, can they wiggle their fingers, can they wiggle their toes? A quick sensory screen where we check to see, does this feel the same as this? Do they have equal strength in both hands? Any potential red flag means we're going to proceed with caution. We're going to look a little further, and if we have any doubt whatsoever whether or not they've got a spinal injury, we're going to treat it like they do. I'd rather package them and send them for further evaluation and not need it than not package them and them need it. Okay, this is too big of a deal for us to guess or to miss. Some other things we'll want to look at here. Where is their pain? What kind of pain are they experiencing? Usually neurologic pain is going to be associated with spinal injury, so sharp, bright, shooting pain, any of those types of descriptors, those are the red flags we're looking for. Any positions or movements that increase or decrease pain, lots of times putting tension across the nervous system is very painful. So if we put them in some selected end range flexion positions, they might not like that at all. Okay. So if we're kind of ruling out immediate threats, and now we're just evaluating, they've got a sore back, one of the first things we'll do is look at their posture. Okay, so a grid can be helpful. A plumb line can be helpful. So this grid allows me to see left or right relative symmetry. This plumb line allows me to see, okay, his ears are a little ahead of his shoulders. His shoulders are relatively in line with his hips, his knees, and his ankles, so not too bad. Left or right, he looks fairly symmetrical from the anterior view. From the posterior view, maybe a little bit of a deviation. Maybe he's got a little scoliosis, or maybe a structural or a functional leg length discrepancy, who knows. But we use these reference marks as a means of establishing what normal posture is for them and how they compare. Now, some posture malalignments we may see. So we see a real subtle case of forward head, a real subtle case of scoliosis here, based on that single photo. Okay. Flat back posture, their pelvis is actually anterior of their knees. Sway back posture, we see this big anterior concavity in the thoracic spine. With lordosis, we see this anterior convexity or posterior concavity in the lumbar spine. And then with scoliosis, we see a deviation from the axis in the frontal plane, looking at them front to back. All right, so when we're looking at the cervical spine, we're going to look specifically at the position of the head and neck, because there's so much mobility in the cervical spine. That may be indicative of what we're dealing with. We look for symmetry, level of the shoulder. So if we go back to that grid real quick, we'll see, if we would apply this grid here, we can see that the patient's left shoulder is a little bit higher than his right. You can see that illustrated in the posterior as well. So that may be an indicator of some tightness in the musculature of the neck. Will the patient move their head and neck freely, or are they moving kind of shoulders first? Okay, so we'll assess active, passive, and resistive range of motion. In the thoracic spine, we look for loss of motion. The lower thoracic region, we're looking for a little bit more mobility than in the upper thoracic. And then if we're concerned that they've got a facet joint involvement, lots of times they'll have pain with a deep inspiration, deep breath in, with their chin tucked all the way down to their chest. Okay, when we make our way further down, lumbar and SI, here we're looking for how well the pelvis moves. Are their hips disassociated from their shoulders? How does their lumbar spine interact with their pelvis? Do they have a flat back posture? Do they have a lordosis? We're looking for symmetry in the soft tissues bilaterally. We'll palpate their iliac spines from left and right and see if they're relatively equal there. And we just want to watch the patient's posture. Okay, lots of times if they've got low back pain, you'll see them kind of grimace and wince just in moving and in single leg stance. Okay, we'll palpate all the way down, level by level, spinous processes, transverse processes where we can, the sacrum and the SI joint, anteriorly on the abdominal musculature and the spinal musculature. We'll have them do a partial sit-up to determine their tone and symmetry. We look to see if that belly button stays put or does it pull one side or the other. And then we can also assess the hip musculature and bony landmarks too. Okay, so just a few special tests we'll do on the spine. First one is a brachial plexus test. We're going to put them in side bend. We're applying a downward force to their shoulder and a lateral flexion force to their head, looking to see if we can reproduce neurologic type pain, sharpshooting pain, shooting down the side that we're tilting away from. Okay. Another test we can do for the cervical spine is cervical compression. So here we're just going to apply a downward force to the patient's head, and we're looking to see does that compression trigger their pain. Sperling sign, they're going to look up and rotate, so we're going to add a rotary component and a little bit of extension to see if they get pain with compression there. One test we'll do before any kind of traction or manual therapy, which is kind of beyond the scope of this course, but you may see if you go out and observe an athletic trainer, you may see them do this test, is a vertebral artery test. This will tell us whether or not there is a circulatory component to their neck pain. So we put them off the edge of the table, extend them and rotate them, and we palpate their pulse. Okay. We're looking to see if they have any dizziness, any nystagmus as a result of occlusion of that vertebral artery. So you don't necessarily have to palpate the pulse right away. We'll do this test, look to see if they're symptomatic, perform the other side, look to see if they're symptomatic, but oftentimes I'll follow that up with a pulse palpation just to see if I can actually feel a difference in their pulse depending on their position. Lots of tests for the lumbar spine, so that kind of wraps up cervical spine. We really don't do much of any tests for the thoracic spine. If I have concerns over thoracic spine problems, I'm probably going to send them for an x-ray, quite honestly. So a lot of lumbar spine tests to look at. First one I like the best is the slump sit, and here we're basically putting the patient in almost a C shape. They're dorsiflexed at the ankle, their knee is extended, their hip is flexed, they are slouched down through their spine, and they're forward flexed at their neck. So what we're doing is putting tension through the entire neurologic system. And with this test, they're going to have pain at end range, and then when they look up or when they plantar flex their foot, their pain goes away. Now what they'll oftentimes tell you is it hurts, but you have to dig a little bit. You have to identify whether or not that's hamstring pain or whether or not it's low back pain. Okay, so being in this position, oftentimes you'll feel tightness in your hamstring. That's not what we're after here. Straight leg raise is kind of a variation on that theme. We put the patient in supine, flex their hip, and dorsiflex their foot, and we're looking to see if we can trigger low back pain there. We are basically putting tension through the system just through the distal tensioning as opposed to systematic. Okay, lots of modifications we can make to this straight leg raise test, so these are all just kind of flavors of the slump sit and the straight leg raise. With the Lesage sign, they're going to raise that involved leg to the point where they get pain down the leg, so this will be for a symptomatic patient, and then we're going to lower that leg until the pain subsides, and then they're going to, the examiner will dorsiflex the ankle to see if we can reproduce it. Okay, so this just helps us kind of confirm that yes, in fact, we are able to manipulate their pain due to tension. Okay, that leads us to Kernig's test. Here they're going to be supine with their hip flexed up to 90, and the clinician will then passively extend their knee. So instead of using the ankle to trigger the pain, like we did before with Kernig's, we're trying to see if we can use the knee extension to trigger the pain. Brudzinski's test is a supine straight leg raise, but this may be more for meningitis. So we have to have them flex their head or flex their neck, flex their chin to their chest, looking to see if this causes pain in the head or neck region. It's another tension test that we can do. If they have pain lower in the system, then this might be a sign for a possible disc or nerve root irritation. The well leg, or the well SLR, straight leg raise. We do this one on the non-involved side. So let's say they had pain shooting down their right leg. We put them in a supine position, pull their hip up to 90. We do that straight leg raise, and we look to see if that triggers their back pain. Okay, and that may also be a sign of nerve root or disc. Okay, Milgram test. This is where we put them supine on the table. They lift their heels up off the table for usually 6 to 12 inches, and they hold that position for up to 30 seconds. Okay, if they can't hold that position due to pain, then that's considered a positive sign for disc or nerve root irritation. If they can't hold that position due to weakness, then that's an inconclusive test. Okay, the bowstring test. This is another modification of the straight leg raise. We move them until they feel pain. We, almost like the slump sit, but on the table. We then can either extend their neck, plantar flex their elbow or their ankle, and then flex their knee and check to see for pain response. So bowstring is pretty much a supine slump sit. Okay, one other one we do for all our patients with back pain is called the Hoover test, and this is a test for malingering. So we have them do an active straight leg raise. If you notice here, the clinician is holding beneath the patient's calcanei, and what she's checking for is if the patient's trying to lift, say, his right leg, he will reflexively push that left leg down into her hand. Now, if he's actually trying, then she'll feel that downward pressure on the non-involved side. If he's not, if he's malingering or faking, then she won't feel that downward pressure. And the way I remember this name is, if they're faking, a Hoover is a vacuum cleaner, and Hoovers suck and cheaters suck. So that's how I remember this one. Okay, some SI joint tests we can do. The Faber and the Fader test. These are named for their position. So flexion of the hip, abduction of the hip, and external rotation puts us in this figure 4 position. This is sometimes called the Patrick's test. So we put them in this figure 4, stabilize the hip with one hand, stabilize the knee with another, and try to apply force. If they get pain in their posterior in the SI joint, then that's a positive test for SI joint dysfunction. The Fader test is flexion, adduction, and internal rotation. Same type of idea here. We put them in this in-range position, kind of crank on them a little bit, and see if we can provoke their pain. Okay, the approximation test, we put them in side lying and apply force down through the pelvis. We can also do this in supine, either straight across their ASIS, or we can try to approximate and push their ASIS apart. Okay, so we can do this test multiple ways, but either way we are looking for SI joint dysfunction. Okay, prone springing test, we put them over on the belly in a prone position. We spring at the level of the SI joint, and this would be considered a positive test for an SI joint sprain or lesion. Percussion, we can do this one just looking for a sign of a fracture or other type of pathology. Have them forward flex at the trunk, and we're going to use the heel of the hand to basically percuss down along various levels of the spine. And if they get pain with any one of those, then that will be considered a positive test. Stork stand, we have them stand on one foot, extend back. We can also have them rotate as they do this. Pain is going to be a positive indication for a spondy. And we'll talk more about spondies in just a minute. But basically this is a slippage of the spine and a deviation from the normal vertical alignment that we have. Adams test, we have the patient forward flex at the trunk, and we look at their spine. So normal, we would have good symmetry from left to right. If they've got scoliosis, they're actually going to rotate a little as they flex, and so we'll see that one side will not be symmetrical with the other. Okay. with the prone press up, we put them in a prone position and we bring them up to this kind of sphinx position first, up on their elbows. And if they don't have pain with that, I can bring them up to flat on their palms. But what I'm looking for here is if they've got a disc injury, going into this extended position is going to be painful. So localized pain is usually a fairly good sign. If they just get generalized, kind of deep, dull, aching pain, that may be an indicator of a disc. All right, now as I said before, when we were talking about the spinal levels, C1 through 8, we have dermatomes and myotomes. And we haven't really discussed this yet this semester, but as you get into eval in the future, if you're a PT or a pre-med or going into athletic training, as you go through each body part, you will also discuss the neuro-eval and basically where the neurologic system innervates that surface anatomy and what levels of the spinal cord actually power the muscles of elbow flexion, let's say, or elbow extension. Okay, so first thing we look at are what are called sensory dermatomes. You see these numbered, so every place you see shading for C2, kind of the angle of the jaw, if I get pain there and I haven't hurt the jaw, but I've got an injury at C2 at the nerve root, then I might get radiating pain here. C3 is kind of the center of the neck. C4 is kind of up around the collarbones. C5 is kind of out to the AC joint. Okay, so I may have pain at the tip of my shoulder, but have never hurt my shoulder before, when in fact it's a nerve root lesion at C5. Okay? I'll also do motor myotomes. Here's where I'll grade this on a scale of 1 to 5, or 0 to 5, for manual muscle testing. And those myotomes will tell me whether or not I've got normal function at the motor level of the spinal cord. I can also do reflex testing, deep tendon reflexes, the level of C5 for the bicep. I'll test that bilaterally, and if I've got a deficit there, and let's say I've also got some numbness or tingling out in my arm, and I've got weakness with elbow flexion, that all those clues point to the fact that maybe I've got a C5 nerve root lesion as opposed to an elbow injury. Okay, so these can all be beneficial in helping me pinpoint whether the pain is actually local to where, or rather, if the pain is actually sourced from the structure or whether it's sourced from the spine or the sensory system. Okay, so that leads us to spinal injuries. First thing we'll look at is cervical fractures. Generally, a fracture results from an axial load. So ordinarily in the spinal cord, we'll go back several slides here and look at this posture again. No, that's too many. Okay, so this patient has a relatively normal cervical spine. Okay, so you notice this anterior concavity, posterior concavity. We've got some amount of extension in our spine. Okay, if we tuck our chin to our chest, we take that extension out, we neutralize it, we end up with a spine. So in this case, I'm looking through the left. So this patient's spine ordinarily would have this anterior convexity. Well, as they forward flex, I end up with a straight line. Now, if I've got this convexity and I load, I've got some cushion there. Okay, if I am in a flexed position, which pulls me down to neutral, everything's just going to compress. Okay, so I lose the slack in the system, so to speak, and I'll end up with the possibility of crushing those adjacent vertebrae, the vertebral bodies together. Okay, so cervical fracture will present with pain. They'll have an unwillingness to move, and we don't want to encourage that. Okay, so if I arrive on the scene and the patient complains of neck pain, the first thing I'm going to do is stabilize their neck, and I don't want them to move from that position until I've ruled out any possibility of a spinal injury. Because in the case of a neck fracture like this, any unwanted movement can result in a neurologic injury, and that's going to be permanent. Okay, so we're going to stabilize them. We're going to put them in a cervical collar and immobilize them, regardless of whether they're conscious or not. Okay, in the case of a cervical dislocation, here we don't have a fracture, but one vertebrae has slipped relative to another. These usually occur from a violent flexion and rotation of the head. So we'll see this, both of these conditions involve a patient who's trying to tackle an opponent by leading with the crown of their head. And in the case of a dislocation, maybe even leading with their face. So this is one of the reasons why the targeting rules have changed pretty dramatically in the past few years, to try to minimize the possibility of this as well as concussions. Okay. These are actually more likely to cause spinal cord injury than a fracture. So we manage these just the same way, package them as carefully as possible. We don't want to move them at all, and we get them to advanced care. Okay, when we talk about strains, now we're talking about stay and play. These aren't load and go. So this can result from a sudden turn of the head. It can even result from sleeping on in an awkward position for an extended period of time. We may need to apply a collar for a severe strain, if they can't hold their head in the proper position. We'll start doing rehab with these, general range of motion exercises, isometric activities to try to reactivate the musculature, and then progress that to full isotonic strengthening. We can use cryotherapy, ice cups, superficial heat, ultrasound, hydroc packs, moist hot packs, and pain medications. All right, along the same lines, so maybe not as severe of a force as we would see in a dislocation, a severe sprain can result from a sudden jolt where we aren't expecting to be moved out of position. Our dynamic stabilizers of the neck musculature isn't firing. So this can be a violent collision. The head or neck or both kind of snap out of position, and this can basically result in a sprain of the ligaments that support the spinal column. Really similar signs and symptoms to a strain, however these probably last longer. An x-ray is going to be negative. This is not a bony injury. They may be tender over both the transverse and spinous processes. Our biggest concern here is to make sure we're not missing a fracture. So we'll probably send them for an x-ray. If the x-ray is clean, they'll not just look at whether or not they have a fracture, but they'll look at the alignment. So first 2 or 3 hours, they may really limit what the athlete is able to do, and then after that start to progress them. Okay, acute torticollis or wry neck. You might have felt this before, pain on one side of the neck when you wake up. As we said, we sleep in an awkward position for hours at a time. We can end up with a little piece of synovium in that joint capsule. That little bit of impingement can result in quite a lot of pain. These usually don't last very long. Longitudinal traction can be beneficial, heat, cold, active range of motion. A soft collar, neck warmer as they're sometimes called, can be helpful for these. So these are, in terms of severity, this might hurt for a day or two, but after that it's usually gone. Cervical spine stenosis, typically this is a congenital condition. So what we see here is we've got a nice space, lots of the white is fluid. We see plenty of room between the spinal cord and the spinal column. But if you notice here, we see this narrowing, and even at some of these other levels, a little bit of narrowing, but certainly at this level we see quite a lot. So we talked about stenosing tenosynovitis. Stenosis means a narrowing. This can result in transient quadriplegia. They can have loss of motor or sensation in all 4 limbs. This usually will start relatively mild, and if they continue to try to play through it, may get a little worse, because if the space is narrowing, the risk of impingement or other traction injury is greater, and then it starts to swell. So if you've got a space that's getting smaller being filled with something that's getting bigger, your symptoms are going to be greater. So these tend to be worse, progressive in nature. And oftentimes, in the case of a collision sport athlete, this may be a reason that they discontinue participation. It's an old movie, but if you've ever seen Any Given Sunday, one of the characters there has talks about having a odontoid fracture and cervical stenosis. Okay, an X-ray may show this, but an MRI is going to show this a little bit better. Okay. Stingers or burners, we see these quite a lot. The patient gets forced into lateral flexion, maybe even rotation, and that brachial plexus gets put on traction, so they end up with immediate, bright, sharp pain down into the body part away from the side to flex to, because this is a traction injury. This may last just a few minutes if it's mild. More severe cases may last a couple of days, and this is not just sensory in nature. There may be a motor component of this too. There'll be weak in elbow flexion and extension, wrist flexion and extension. Because if you remember back to our dermatomes and myotomes list, our lower cervical vertebrae power the upper extremity. Okay. Management for this is pretty tough. We can try something along these lines, like a neck roll or a pad. In other sports, there's not a whole lot you can do, but in sports where they wear shoulder pads, we can apply restraints that keep them out of these extended or terminal end range positions. This is Brian Cox. He's now a Hall of Famer, but he's kind of known for wearing this kind of backboard that keeps him out of extension. You'll see very few players still wear these, but you may see these cowboy collar or neck rolls. Like I said, they're not very popular anymore. With disc injuries, we've got the possibility here of a couple of things. This could be just straight up compression like we see here, where that compression kind of forces that nucleus out of the annulus, or lots of times in chronic cases, we said that this annulus is kind of ringed shaped, and with lots of rotation we can actually fissure or crack those layers that allows that nucleus to make its way out. So lots of times with this we want to reduce the amount of impact loading that they're having. We want to keep them out of terminal flexion or extension, because those increase the interdiscal pressure and increase the risk that we are protruding that nucleus out. Okay, low back pain in general can be a result of congenital differences. It can be the result of trauma. It can kind of add up from chronic recurrent conditions. So lots of options as far as what we can do here. We can try to improve their posture. We can try to strengthen the weak side and stretch the tight side in order to improve their segmental mechanics. We know that any adult is likely to have, let me restate this, about 80% of all adults are likely to have back pain at some point in their life. So this is not uncommon, certainly not uncommon in our athletes, and the poorer their mechanics, the more likely they are to have a spinal injury that involves low back pain. Okay. In the case of a lumbar vertebrae fracture dislocation, our concern here is, because those bodies are so much thicker and designed to bear load, then we have to monitor impact loading even more so than we did when we talked about cervical spine injuries. Okay, so a compression fracture requires an X-ray. They're going to have pain and point tenderness over that affected area, maybe even palpable defects. We're going to manage this with a physician referral, and this is going to be a patient that gets spine boarded too, not just cervical spine injuries, get spine boarded. Low back muscle strains, very similar in nature. A sudden contraction. We'll see this. Sometimes patient gets out of position, or there's a sudden change in direction, so they end up with a muscle strain. The key to this one is it's not midline. Usually midline is going to be disc or vertebrae related. Usually this is going to be lateral to that, and one side or the other. It's rare that we're going to have a low back muscle strain that's bilateral. Okay. Long-term corrective exercises and core strengthening are going to be beneficial. We might teach them how to lift with your legs, not with your back, that kind of thing. Myofascial pain syndrome. This occurs when we develop mechanical stressors to the muscles, and we end up with trigger points in the fascia itself. This could include muscle strain, but it also involves postural abnormalities that make the likelihood of strain more likely. Okay. In the case of piriformis, they'll get pain usually in the deep buttock, posterior SI joint, sacroiliac region, and a deep ache that gets worse. In the case of quadratus lumborum, it's a little higher up on the spine, so think iliac crest up to the 12th rib. That's going to be QL. Piriformis is going to be iliac crest down to the hip. Okay, so we're going to manage this with stretching and strengthening of that involved muscle. Try to get them back to normal length. Work on their posture. Some other conditions we have: sciatica. This is just an inflammatory condition of the sciatic nerve. We usually want to rule out something like piriformis syndrome first to see if there's a structural reason for this. These usually come and go pretty quickly, so they'll get sharp shooting pain, tingling, numbness, maybe even some motor deficits, but rest is our key here. Treat that inflammation. Longitudinal traction if we've got a disc involvement here, but these will usually resolve pretty quickly. Coccyx injuries, we see these usually as a result of a forcible sit down, slip on the ice. I've seen this more often than not because a patient either slipped on the ice or they got tripped up in a court sport and they landed right on their rear end. This can be very painful, very debilitating. X-rays and even a rectal exam may be required to determine the extent. Analgesics and a hemorrhoid ring seat can relieve pressure while they're seated or sitting, and that pain from a fractured coccyx could last for months. Okay, so this one, not a whole lot you can do about it other than just protect them. Know that it's going to be a long healing process, but there's no way to splint this. There's no way to tape this. It just kind of is what it is. Okay, spondies. We've mentioned this briefly. A spondylolysis, easy for me to say, is a degeneration of the vertebrae at the pars interarticularis. This is the juncture of kind of the front half of the vertebrae to the back half of the vertebrae. Okay, with a spondylolysis, we end up with a fracture here. They get irritation, but no translation. In the case of a spondylolisthesis, this is an actual slippage. So we get the spondylolysis, but because, in particular, L5 is kind of on an angle, that vertebrae starts to separate apart, and that L5, in this case, slips anteriorly. Like we said with a dislocation, if that vertebral column is not lined up, you can kind of think about this like two sheets of paper with a hole in them. Pause this real quick and I'll show you that. Okay, I'm back. If we consider these levels with the holes in them to be lined up over one another, when they are in alignment, the opening, the foramen, is lined up with one another and the structure can pass right through. So at the level of L5, we're not talking spinal cord anymore, we're talking cauda equina, but it's still nerve tissue. So if one slips anterior to the other, we see how that opening is cut down, and we end up with nerve root irritation, nerve root compression, because one layer is sliding or slipping relative to the other. Okay. We end up with numbness, tingling, pain that shoots down over time. This may also result in motor deficits, but lumbar stabilization is absolutely essential. I had this in almost all of the gymnasts I work with because they get into this extended position a lot more than most athletes, and that puts that pars interarticularis at risk. So lumbar stabilization, core stability is absolutely essential because that muscular corset, the muscles that surround the core, can help keep that spinal column in position where it needs to be. Okay, treatment here is going to consist of long-term management. There's no magic bullet for this. Bracing a compressive brace can be beneficial. If they're really acute, they may even be prescribed to bed rest. Most of the time with athletes, they'll put them in a brace and tell them not to practice. But the key is going to be progressive trunk strengthening. So core, abdominal work, those kinds of things can be very helpful. Okay, when we look at the SI joint, sprains aren't terribly common here, but they do happen. In most adults, we've got quite a lot of bony interface between the pelvis and the sacrum, and there's lots of strong ligaments that hold this in position. But in particular, if we're doing single leg stuff that introduces a lot of torque, then we can potentially injure or otherwise irritate that SI joint. Okay, so with pelvic rotation, hypomobility is the norm. So we have to be cautious here, because now we end up with hypermobility, and every time we do something on a single leg, it's putting torque through that pelvis and it's irritating that injury. So these can be kind of slow healing as well, because almost everything we want to do, whether ADL, activities of daily living, or athletic, can make the injury a little worse. Okay, so management here, modalities can be helpful for pain. Bracing can be helpful. We can use what's called an SI lock. It's basically a belt that goes right around the iliac crest, or rather the ASIS, and it attempts to engage both halves of the pelvis so that that bony interface I discussed can provide more stability. We may need to do some mobilization to the SI joint if it's out of position. So chiropractors will oftentimes do this. Other healthcare professionals that have been trained in muscle energy techniques can do this. And then we want to do strengthening exercises to help stabilize the joint. All right, we are done. So I appreciate your attention this semester. There will be a study guide posted in the week 16 folder, if I'm not mistaken. It is comprehensive, so make sure you take a look at how many questions are going to come from each of the chapters. And just know that I won't ask any questions that we haven't talked about in class, and in most cases also in the textbook. So best of luck to you, and if there's anything else I can do, let me know. This is Dr. Brooks signing off. Good luck.